Hello, I'm Melinda Gooderham, a dermatologist and clinical researcher at the Skin Center for Dermatology, Probity Medical Research, and Queen's University in Peterborough, Ontario, Canada. And I'd like to present on growing up with atopic dermatitis, achieving sustained outcomes for moderate to severe disease. I'd first like to start with why is an accurate assessment of the burden of moderate to severe atopic dermatitis critical? Before I can do that, I want to take a step back and look at the worldwide incidence of atopic dermatitis, which is up to 20% in children and up to 3% in adults. Atopic dermatitis can present very early. About 60% of patients develop disease by age 1, and 90% will develop disease by age 5. We know that 17% of adults with atopic dermatitis experience onset after adolescence. And of those children and adolescents with atopic dermatitis, symptoms will persist into adulthood in up to 1/3 of patients. So let's consider the patient journey. First, we need to establish a diagnosis. And in atopic dermatitis, there are some essential clinical features. So whether you're considering adults or infants and children, patients will have pruritus, as well as the classic dermatitic lesions with erythematous skin with vesicles. What differs in the different age groups is typically the locations of presentation. In the younger kids, we see face, neck, and extensor involvement. As kids get a bit older, go into adolescence and adults, we see more flexural involvement with sparing of the groin and axillary regions. Once a patient develops atopic dermatitis, it presents with a chronic relapsing course. And there are 3 different clinical phases. There's the acute phase, which is typically vesicular, weeping, and crusty with excoriations. We then have the subacute phase of AD, where it's more dry, scaly, has erythematous papules and plaques. And then there's the chronic atopic dermatitis, which is more like canified, thickened, and shows more chronic features of the disease, sometimes associated dyspigmentation. And once patients are presenting with this, they will typically modify their behavior to try to control this disease. So they may have some gentle skincare practices where they're using regular emollients or moisturizers, and they often avoid triggers that they believe is causing the atopic dermatitis. These may be environmental triggers, or they may avoid eating specific foods they believe may be flaring their dermatitis. So when patients are doing these behavioral changes, this may help and they may continue on in that fashion. But if it's not working and the symptoms are uncontrolled, they typically seek medical attention and are given topical medications, usually starting with topical corticosteroids or calcineurin inhibitors. In more extensive disease, they may also have phototherapy. And if those treatments are working, they typically continue on with those on an as-needed fashion. However, if their symptoms are uncontrolled or their disease worsens over time, patients may be candidates for systemic therapy. And in that case, we consider that they have moderate to severe disease. However, I've only been talking about the skin presentation of atopic dermatitis, but we fully understand that atopic dermatitis goes deeper than the skin. There is a burden associated with these recurrent symptoms. And you can see from this one study with adults with moderate to severe atopic dermatitis who scored a DLQI of 6 or greater, that over half of them reported a sleep disturbance, 70% reported depression, and 60% reported anxiety. This resulted in reduced physical and overall health, as well as an increase in work impairment. We know that burden of atopic dermatitis has a significant impact on mental health. You can see that in adults, the prevalence of suicidality was 12% in patients with atopic dermatitis, compared to only 6% in those without atopic dermatitis. The odds ratio for suicidal thoughts was 2 in patients with atopic dermatitis compared to those without. And this burden is not only in the adults with atopic dermatitis, this burden is also in the children and their families. So the impact of pruritus in the younger kids, in the infants and children, can lead to a lack of attention, both at home and at school, irritability, as well as sleep disturbance. There's also an increased odds ratio for depression in children with atopic dermatitis and their parents. And you can see an increased odds ratio in those with atopic dermatitis compared to those without. So that assessment of the severity of atopic dermatitis and its impact on quality of life is so important. So after we've established a diagnosis of atopic dermatitis, where there is no universally accepted test or biomarker or assessment tool, we do have to consider both the clinician assessments, the objective measures of disease, as well as the patient's subjective measures on their patient-reported symptoms, such as itch and sleep disturbance, as well as quality of life impact. And we do that so that we can classify patients into mild, moderate, or severe disease, because this will impact how we treat the patients moving forward. The greatest challenge being that there is no gold standard for defining these disease severity groups. So we have a number of different measures that we use to assess the severity of atopic dermatitis and its impact on the patient. So the objective measures listed here that can be done by a clinician, the EASI, the SCORAD. We have the physician global assessment or body surface area. And then we have more specific atopic dermatitis scores. So the atopic dermatitis severity index, the 6-area, 6-sign of atopic dermatitis, but we know that the EASI and the SCORAD are the two outcomes that have been validated for use in both clinical trials and in the real-world clinical setting. So we tend to focus more on the EASI and the SCORAD, and you can see how they're used here to define disease severity. So the EASI score, which looks at 4 clinical signs: erythema, edema papulation, excoriation, and lichenification. And these are graded in 4 defined body regions with a nonlinear score from 0 to 72. And then we have the SCORAD, which looks at 6 clinical signs, but it also includes the patient's perspective with the pruritus and sleep loss score incorporated with a score anywhere from 0 to 103. Then there's the subjective measures of the patient. We can look at severity of symptoms with the POEM, the pruritus NRS, and skin pain NRS. And we have our dermatology, but not AD specific quality of life tool, the DLQI, which is a 10-item questionnaire. So the POEM, the DLQI, and pruritus NRS are the most often that are used in clinical trials for atopic dermatitis. It's also very important when we are assessing the quality of life in our pediatric patients and their parents or caregivers. We have our general dermatology tools, the DLQI, the children's DLQI, or the family DLQI. We have some more age-specific tools. And then we have the atopic dermatitis-specific tools, such as the Dermatitis Family Index or the Childhood AD Impact Scale. These more specific tools are not typically used on a daily basis in clinic and are more likely to be used in clinical trials. So just to summarize the importance of coming up with that diagnosis, defining their disease severity using both objective measures and subjective measures, and then looking at the clinical characteristics of the disease. Is the disease persistent? Is it recurrent? What are the locations that are involved, and how has it responded to treatments in the past? And all of this information can then help guide us in our treatment choice so that we can control the symptoms for our patients. We can reduce the disease burden and provide our patients with the best care, giving a high benefit to risk ratio so that we can improve the disease, the quality of life, without introducing new safety risks. Thank you. Next, I'd like to look at, can systemic therapy achieve sustained control of signs, symptoms, and quality of life in atopic dermatitis? So we can see as patients receive a diagnosis of atopic dermatitis and they try basic skincare measures such as behavioral interventions, using regular emollients, avoiding triggers. When their symptoms are uncontrolled, we would then move on to topical medication, such as topical corticosteroids, calcineurin inhibitors, and in more extensive cases, phototherapy. When that does not work to control the symptoms or patients develop an increase in the severity of their disease, we would move on to systemic therapy. And at that point, we would consider the patient having moderate to severe disease. In the past, we've only had the conventional systemic options for the treatment of atopic dermatitis, including cyclosporin, methotrexate, and azathioprine. The biggest challenge is that these medications are considered off-label use in many countries in North America, and cyclosporin is the only medication that is licensed in some European countries and Japan to be used in patients with atopic dermatitis. Although it can be quite effective for some patients, it is associated with some side effects and off-target effects, such as nephrotoxicity and hypertension, and therefore not appropriate to use in a long-term manner and is typically limited to a 2-year continuous regimen of therapy. And as we know, this is a chronic condition requiring ongoing care. The other approved systemic therapy for atopic dermatitis is Dupilumab, a monoclonal antibody to the interleukin-4 receptor alpha subunit, which inhibits signaling of both interleukin-4 and interleukin-13. This medication has received approval for moderate to severe atopic dermatitis, not controlled with topical treatment, back in 2017 for adults, in 2019 for adolescents, and most recently in 2020 for children aged 6 years and above. First, let's focus on the data for adults and adolescents. So we will look at the pivotal trials SOLO-1, SOLO-2, CHRONOS, and Liberty AD adolescent, which were clinical trials carried out with participants with a diagnosis of moderate to severe AD with an IGA score of 3 or greater in patients not controlled by topical therapies. The primary endpoints for all 3 of these trials, or all 4 of these trials, was an IGA score of 0 or 1 from baseline to week 16, and an EASI-75 at week 16. And you can see here in a summary of the results. So SOLO-1 and SOLO-2, and Liberty AD adolescent being the monotherapy studies, and CHRONOS being a combination study. Dupilumab outperformed placebo with a significant benefit in anywhere from 21% in the adolescent study up to 37% in the adult studies, those patients achieving an IGA score of 0 or 1 and a 2-point or greater reduction from baseline. When you add in the topical corticosteroid, as we see in CHRONOS, that IGA response rate increases up to 39% at week 16. Looking at EASI-75, we see a similar pattern. Anywhere from 40 to 50% of adolescents and adults with monotherapy achieve an EASI-75. When you add in the topical corticosteroid, 2/3 of patients in CHRONOS achieved an EASI-75 at week 16. Looking now at the longer-term improvement in CHRONOS. So here we have the combination study, the 2 doses of Dupilumab every 2 weeks or every week, anywhere from 36 to 40% of participants achieving an IGA score of 0 or 1 compared to placebo at week 52. And the EASI-75 achieved in 2/3 of patients by week 52 with both doses of Dupilumab. So the study design in SOLO continue. This is where patients with moderate to severe AD who participated in SOLO-1 or SOLO-2, if they achieved an IGA score of 0 or 1 or an EASI-75, they were allowed to roll over into the SOLO continue study. And if we look at the design here, you see they have from week 0 to week 16 in SOLO-1 or SOLO-2. If they are a responder of either IGA or EASI-75, they were then re-randomized in a 2-to-1 to 1-to-1 fashion to either stay on their current dose of Dupilumab every week or every 2 weeks, or they would drop down to Dupilumab every 4 weeks, every 8 weeks, or placebo. And they would continue this on to week 36. And what we can see here is that maintenance of response over time was most consistently maintained in those patients who maintained on their current regimen of weekly or every 2 weeks doses of Dupilumab. Those participants who dropped down to every 4 weeks or every 8 weeks started to lose response, and those patients who came off therapy and were switched to placebo were losing response over that 36-week period. So it's clear that staying on your current regimen gives you the best chance at maintaining the benefit. So if we look at the overall proportion of patients with EASI-75 in SOLO Continue, again, we see that those on weekly or every 2 weeks Dupilumab did the best, with 72% of patients maintaining their EASI-75. And those rates of EASI-75 dropped in the participants who switched to every 4 or 8 week dosing, and dropped the greatest in those who were switched to placebo or came off of therapy. Overall, Dupilumab in all of these trials was very safe therapy. The only AEs that we noted more in the Dupilumab group compared to the placebo group were injection site reactions and conjunctivitis. And you can see from these numbers here from CHRONOS, Liberty AD Adolescent, and Liberty AD Peds that there was a higher proportion of patients, anywhere from 10 to 18%, who reported conjunctivitis compared to 4 to 8% on placebo. When we look beyond the skin scores that I've just mentioned, the EASI-75 and the IGA 0/1, and think about pruritus, we can see here the Dupilumab shown in blue for SOLO 1, SOLO 2, CHRONOS, and Liberty AD Adolescent, a very rapid improvement in itch. And this was maintained out the 52 weeks, as we saw in the CHRONOS study, significantly greater compared to the placebo patients. And also that quality of life that we know is so important for these patients. Looking at the adult patient-reported outcomes in SOLO 1 and SOLO 2, we see a significant reduction in both doses of Dupilumab in the POEM scores, with change from baseline approximately 6 points compared to 1.6 with placebo. And in DLQI, that quality of life measure that we use frequently, we see a 5 to 6 point reduction with both doses of Dupilumab compared to only a 2-point reduction with placebo. And anxiety and depression, we know the burden of mental health on these patients, and measuring with the HAD score in SOLO 1 and SOLO 2, again, a significant reduction with both doses of Dupilumab compared to placebo with respect to anxiety and depression, not only at the first 2 weeks, with increased benefit over 16 weeks. So all of the results that I've shown so far are from the clinical trials. These are very defined populations with strict protocols. But what happens when you take Dupilumab and you use it in the real world? Well, this is why we are doing the PROS registry. And you can see here from some of the initial results from the PROS registry, looking at a combination of objective and subjective measures. We see a rapid reduction in body surface area and EASI in those first 3 months of treatment in the real world. We also see a reduction in the patient-reported outcomes of PPNRS, which is peak pruritus NRS, the POEM, and the DLQI. There's a significant reduction in all of these measures in the first 3 months, and this is maintained throughout 18 months of treatment. We also saw improvement in the proportion of patients reporting that they were doing very good or excellent on the PGAD questionnaire, with 10% of patients at month 0 of treatment or initiation of treatment. This rapidly improves over the first 3 months and continues to improve over 18 months of treatment. So this is the adolescent and adult data for Dupilumab in both the clinical trials and the real-world PROS registry. Now, what about the children in the AD-PED study who are aged 6 to under 12? We know that we have approval for this medication in this age group starting last year in 2020. Let's look at the data to support this approval. So we have Liberty AD Peds in those children who are 6 to 11 years old, which supported the approval. And we also have some newer data in a younger age group. So Liberty AD Preschool, which was 162 infants and children aged 6 months to 6 years. Now, these younger kids, to qualify for these studies, had severe atopic dermatitis with an IGA score of 4, who were not controlled by topical treatment. Again, the primary endpoints here of an IGA score of 0 or 1 and an EASI-75 at week 16. And here are the efficacy results at week 16, very similar to the adolescents and the adults, where we see almost a third of patients achieving an IGA score of 0 or 1 by week 16, and an EASI-75 from 53 to 68%, depending on the age group. But clearly a significant benefit in these children with Dupilumab compared to placebo. And the quality of life in the children, which we know is so important, looking again at weight-based division here at 30 kilograms, and the children's DLQI score, the CDLQI, we see benefit in a 6 to 7 point reduction as early as 2 weeks. And when you go out to week 16, we see even a greater improvement with a 10-point reduction from baseline in both the less than 30 kilograms as well as the greater than 30 kilograms group, which was significantly greater than the improvement seen with placebo. And one thing that I really find interesting about these studies, and I think is so important because we know there is an impact of the atopic dermatitis, not only on the patient, but the entire family, we see an improvement in the quality of life of the family. So here we're looking at the Dermatitis Family Index from week 0 of treatment out to week 12. We see an improvement with Dupilumab over time with that dermatitis family impact, which looks at things like housework, food preparation, sleep, all of those things that goes beyond the patient, but also extends into their family impact. There's also new treatments coming. This whole landscape of atopic dermatitis is changing as we learn more about the pathophysiology and we learn more about how we can control the inflammation of this disease and reduce the burden on patients. We have more monoclonal antibodies coming. There is tralokinumab, which is a monoclonal antibody against interleukin-13. It has already received regulatory approval in Europe and in the UK. We have another monoclonal antibody against interleukin-13, lebrikizumab, which is currently in phase 3 trials, as well as nemolizumab, another monoclonal antibody against interleukin-31, the known itch cytokine. There are also a number of oral systemic molecules, the JAK inhibitors. We have specific JAK1 inhibitors with abrocitinib, recently approved for use in adults and adolescents greater than 12 years in the UK. And we have upadacitinib, another JAK1 inhibitor approved for use in adults and adolescents 12 years and above in Europe. Last year, we had the approval in Europe of baricitinib, a JAK1/2 inhibitor for adults 18 years and above with moderate to severe AD. So there's really been an explosion of new therapies and new options for patients to be able to control this disease that has such a deeper impact than just the skin. So to summarize this portion, we know that we need to do a holistic assessment of the patient, not only looking at disease severity, also impacts on quality of life, considering symptoms such as itch, sleep disturbance, and other individual patient factors. This will then help us make a decision to choose the most appropriate therapy for our patients, whether it is a systemic biologic or small molecule therapy, because we know that there is improved disease response, improved quality of life. We may prevent disease progression and possibly future comorbidities. So looking at the efficacy of a therapy and comparing that with the safety of the therapy so that we can overall offer a high benefit with a low risk and provide that patient an improvement in their symptoms and quality of life in a safe manner. Thank you. Next, I'd like to look at how emerging systemic therapies may change the management of moderate to severe atopic dermatitis. But first, I'd like to think about the pathophysiology of atopic dermatitis so we can think about how these medications are working. We know that the epidermis provides multiple functions, including barrier protection as well as an immune response. And in atopic dermatitis, we have a dysfunctional epidermal barrier, which allows the penetration of irritants, allergens, and pathogens, leading to a dysregulated inflammatory response. The keratinocytes can release alarmins, such as TSLP and interleukin-33, which can stimulate innate lymphoid cells to develop a type 2 immune response. We get the differentiation and proliferation of Th2 cells, along with some other lymphocytes, including a Th1, Th22, and Th17 cells. Why this is important is that all of these lymphocytes use the JAK-STAT signaling pathway to transmit their signals. So there's a number of inflammatory cytokines that are important in the pathophysiology of atopic dermatitis, including the key cytokines interleukin-4 and interleukin-13, but also that itch cytokine interleukin-31. And then we have interleukin-22, which is responsible for the hyperproliferation of keratinocytes and the lichenification that we see. But a number of other functions, such as barrier dysfunction, pruritus, keratinocyte hyperproliferation, and B-cell IgE switching are all dependent on these cytokines, which use the JAK-STAT signaling pathway to transmit the signal. So this makes targeting these inflammatory pathways possible in two ways. We can do it outside the cell with the biologics targeting monoclonal antibodies, such as interleukin-13 or interleukin-31, or we can do it inside the cell with the JAK inhibitors, blocking those JAK-STAT pathways with JAK1 inhibitors, abrocitinib and upadacitinib, or the JAK1/2 inhibitor, baricitinib. So these are all the agents that are currently in clinical trials, and I'd like to go over some of the pivotal trials with you today to discuss these agents. So for tralokinumab, we have the extra trials here in adults 18 years and above. Tralokinumab, 300 milligrams every 2 weeks compared to placebo. For lebrikizumab, we have here the phase 2 program, although we know lebrikizumab is currently in their phase 3 trials, but the phase 2b program looked at multiple doses of lebrikizumab versus placebo. And then nemolizumab, also in phase 3, we have here the adolescent and adult trial, 13 years and above, comparing nemolizumab, 60 milligrams every 4 weeks versus placebo. So let's start with the tralokinumab extra trials, tralokinumab versus placebo. We have the monotherapy studies, extra 1 and extra 2, done in adults 18 years and above with moderate to severe atopic dermatitis. And we also have extra 3, which was also done in adults, but is a combination therapy study looking at tralokinumab versus placebo with topical corticosteroids. The both programs, extra 1 and extra 2 monotherapy, as well as extra 3 combination therapy, compared tralokinumab every 300 milligrams every 2 weeks versus placebo, with the primary endpoint of IGA score 0 or 1 or in an EASI-75 at week 16. And looking here at the results, in the monotherapy studies, we have an IGA response from 16 to 22%. When you add in the topical corticosteroid in extra 3, that increases to 39%. Similar with EASI-75 improvement, 1/4 to 1/3 of patients achieving EASI-75 by week 16. When you add in the topical corticosteroid, we have an EASI-75 response rate of 56%, all superior to the placebo response. These studies, extra 1 and 2, as well as extra 3, did roll over into a maintenance period. So when patients, if they achieved an IGA score of 0, 1 or an EASI-75 by week 16, they were then re-randomized into the maintenance study with extra 1 and 2. This was in a 2 to 2 to 1 fashion to either stay on tralokinumab every 2 weeks, drop down to tralokinumab every 4 weeks, or placebo, and follow the maintenance period out to week 36. In extra 3, patients either stayed on Q2 or dropped down to Q4 for the maintenance period of 16 weeks. And we can see here that staying on tralokinumab every 2 weeks throughout the maintenance period provided the greatest chance of maintaining that benefit of a IGA score 0/1 or an EASI-75 in both the monotherapy studies or the combination studies. Dropping down, however, to Q4 week dosing still provided significant benefit for some patients. Those subjects that were switched to placebo, shown here, had the lowest chance of maintaining that response rate of IGA 0/1 or EASI-75 during that maintenance period. So again, we know that staying on a therapy, maintaining your current dose, is the greatest chance of maintaining benefit. Looking at AEs, again, we saw similar with tralokinumab in an AE profile as we did with Dupilumab, where the only differences with placebo were things like injection site reactions and conjunctivitis. And you can see in tralokinumab in extra 1, 2, or 3, we did see greater rates of conjunctivitis in the treatment group compared to placebo, with rates anywhere from 5 to 13%. Moving on now to the JAK inhibitor monotherapy studies for atopic dermatitis, we have JADE Mono 1 and Mono 2, which investigated abrocitinib 200 milligrams daily versus 100 milligrams versus placebo in a 2:1 fashion. That included participants who were aged 12 years and above. Measure Up 1 and Measure Up 2, also in adults and adolescents, investigated upadacitinib 30 milligrams versus 15 milligrams versus placebo. And Breeze AD1 and Breeze AD2 looked at adults with baricitinib receiving either baricitinib 4 milligrams, 2 milligrams, 1 milligram, or placebo over the first 16 weeks. Looking here at the study outcomes, we do have a wide range of responses with the different JAK inhibitors. Although they have similar targets, they do have some differences, both with respect to their efficacy as well as their safety. Looking here at the IGA 0 or 1 scores from reduction from baseline, you can see the highest dose of JAK inhibitors will provide the greatest benefit. And this does vary anywhere from 15% with the highest dose of baricitinib up to 57% with the highest dose of upadacitinib. We know the second highest dose does provide the next benefit, but all of the JAK inhibitors provided more benefit than placebo in each of these trials with respect to IGA score of 0 or 1, as well as EASI-75, where we see the same trend. Highest dose of baricitinib, 1/4 of patients can achieve an EASI-75, compared to 60% with abrocitinib, 200 milligrams, compared to 76% with upadacitinib, 30 milligrams. So again, some variation in the level of efficacy, but clearly the higher doses of JAK inhibitor do provide more benefit to patients than the lower doses. I mentioned there is some variation from one JAK inhibitor to another. As a class, we see some common themes with respect to adverse events: nasopharyngitis, upper respiratory tract infection, headache, things like nausea, acne, as well as herpes infection signal seen with all of the JAK inhibitors. Of course, the proportion of patients experiencing these adverse effects can differ from one JAK inhibitor to another. We don't have a lot of data beyond those initial pivotal trials, some longer-term data, but there are still some questions we need answered with respect to use of JAK inhibitors in the clinic. So one would be the reduced dosing over time. We do have the JADE regimen study here, which investigated the use of abrocitinib after an open label period of 200 milligrams for 12 weeks. Patients were then re-randomized to either stay on 200 milligrams daily, drop down to 100 milligrams daily, or placebo. And they looked at the proportion of patients experiencing flares during that maintenance period. And again, those participants staying on the dose of 200 milligrams were least likely to have a flare, with 16% of patients, compared to those who dropped down to 100 milligrams of abrocitinib, where 40% of patients experienced a flare during the maintenance period. But those patients who came off of therapy and were given placebo had the greatest chance, with almost 80% of patients experiencing a flare during that maintenance period. Again, solidifying that notion that patients who stay on therapy have the greatest chance of continuing to do well. We also need more information on how the different modalities of therapy work compared to each other. So how do monoclonal antibodies compare to JAK inhibitors? How does targeting outside the cell compare to targeting inside the cell? So we have the JADE Compare study. This is not a head-to-head study. It is an active comparator looking at 2 doses of abrocitinib, 200 milligrams versus 100 milligrams versus placebo, with the active comparator of Dupilumab. The primary endpoint was an IGA score of 0 or 1 at week 12 and an EASI-75 at week 12. But this study was powered to look at the differences between abrocitinib versus placebo at week 12. And here we can look at the efficacy results. Again, we see the highest dose of abrocitinib, 200 milligrams, providing the most benefit, with almost 50% of patients achieving an IGA score of 0 or 1 and 70% of patients achieving an EASI-75. Abrocitinib 200 milligrams was more effective than 100 milligrams of abrocitinib and placebo. And although the study was not powered to compare Dupilumab with abrocitinib, we see very similar levels of response with Dupilumab versus the 100 milligram dose of abrocitinib. There is another phase 3 study called JADE-DARE, which is a head-to-head study, which will be powered to compare the different doses of abrocitinib with Dupilumab. So we'll need to stay tuned for those results. So overall, when we look at that future of systemic therapy for moderate to severe AD, after we do our holistic assessment of our patient, not only looking at skin scores as far as baseline EASI, we also have to consider the patient's perspective, those patient-reported outcomes. What is the impact of itch? What is the impact on sleep? And when we get a full picture of our patient, we can then grade their severity into mild, moderate, severe, and consider those patients that will benefit from systemic therapy. And then when we make that decision, we have a number of options. We have cyclosporin with its limitations of end organ toxicity and limitations on continuous use. But now we have more options. We have Dupilumab, which is approved from age 6 up to adults. And now we'll have newer biologics that are targeting the interleukin-13 cytokine, the interleukin-31 cytokine. But we can also target inside the cell, targeting those JAK-STAT pathways that are used in the inflammatory cells, so important for the pathophysiology of AD. We'll have a number of JAK inhibitors, particularly JAK1 selective or JAK1/2 selective therapies to target our patients' atopic dermatitis so that we can relieve that burden, improve their quality of life, and hopefully give them their life back.